This has been a bit of a shift for us, looking at causal factors, multiple causation. It's not just one thing that went wrong, and identifying anywhere that a mistake or failure could have prevented the incident or mitigated the consequences of the incident. So even just that language of identifying causal factors, drilling down to root causes, our team typically will lead this part. The clinical team don't have the patience to do that, but we'll often guide them through and check the root causes with them, and then coming up with recommendations. And we force this piece through our recommendation table, corrective action tables, to say, what was the causal factor, what was the root cause, and what are you going to do to fix it? And you know, sometimes we get people trying to slide in corrective actions that really have nothing to do with this incident. Something that they've been wanting to do, and we're like, we're resource lean, make sure what we're doing is the right thing to do to prevent recurrence. So of course our recommendations need to be effective. They need to fix those root causes. They need to be, and we're always, like the process does not stop. So we really need to be mindful of interim actions as well as getting our recommendations put in place. And lastly, I mean, ideal if they're inexpensive, but if we're looking for those stronger fixes, they really ought to be engineering fixes or physical safeguards. Not always possible, but that's our goal. But of course, if the intersection of those three is that magic sweet spot, right? So if you find an effective, fast, and inexpensive corrective action, then just ride that unicorn to the AMC and tell them all about it. But they're few and far between, so we really have to think long and hard and get the right people involved to make those decisions about spending resources, time, people, or dollars. The other piece of this is how we support our people. Talking about errors, especially when someone is harmed at the hands of the care provider, is very, very difficult. Carol, thank you today for talking about it. It's hard, it's something people carry a long time. Any healthcare provider that you talk to, and you talk about errors, everybody's got that story or that patient. And we have something we call artichoke rounds. We talk about errors from the human side. People will come and tell stories 30 years later, and they can't tell the story about that incident without tearing up. We had our president and CEO come and talk about errors or difficulties in his career as a physician, and he could hardly get through the talk. So we spent some time prepping people by talking about vulnerability, and this is stuff from Brene Brown's work on that. It's not weakness, it's the birthplace of innovation, creativity, and change. And if we don't have vulnerability, then people will hide in the darkness of shame. And they don't talk about it, and there's no healing, and there's no solutions, and it becomes a very dark, lonely place for our caregivers. So when we talk about vulnerability, we also express that we need empathy to be able to talk about these incidents, whether they're in incident debriefs or in other forums. And with that empathy, it leads to connection. And that's really what humans crave, right, is connection, somebody that understands. And so as a result of this is a big part of the way we do our reviews. And I'll talk about that from one of our directors' perspective. But that connection creates a powerful and fertile ground for learning and adopting and accepting improvements in the processes and systems and actually using them. And it's also an important part of healing. So we do spend time talking to our leaders about this piece. It's not a public shaming, it's really meant to be healing and learning. It also helps people to recognize that when they don't do something that they should have done and they know they should have done it, that we need to depend on each other to hold ourselves accountable. And that the dark side of trust is that, well, I know Carol's a great nurse, so she said this is what's in the vial, I'm going to take her word for it. I don't have time to check. And this helps us to realize there's a cost to that. Not only a cost to the patient, but a cost to ourselves and our care providers. So we have different forums that we can use to share and help support people and build that energy that creates the resilience. And it's through our quality of care reviews. Our leadership team is very good to acknowledge to the directors and the owners and the physicians, owners of the process, those changes to help move that program forward. We have clinical committees that we share those incidents at. And the Artichoke Rounds is a non-clinical review, not like an M&M round, but it's a non-clinical, high-level review to talk about the impact of those errors, the changes, the improvements made, to kind of talk about the legacy of learning from these incidents, as well as the pain that goes along with the errors. And so not doing what you're supposed to do, what you know you have to do. We have a focus on back to basics right now. Is not only not good for the patient, but it's not good for you, because if something happens, this is a burden you carry for a long time. So it's really helped to strengthen our culture, what we call the South Lake Way. So I'm just going to talk briefly about a case study that came from our heart rhythm team. We're one of the regional cardiac centers, the third largest in Canada, and we have a very highly skilled, highly motivated, high-functioning team. And actually, Matt's back here. He's the manager of that team. He's a very strong leader. I wouldn't call him the warmest and fuzziest, but he's a pretty good leader, very cohesive team. They've been working together. I think the program started in 2011, so they've been together for quite a while. This was an incident where a 68-year-old patient was referred for an ICD, an implantable device, defibrillator device, and got the wrong device implanted. Now the error was caught. This is a day procedure. They went in for the procedure. The error was actually caught in the post-op before the patient went home that day. When the nurse checked in with the patient, asked, "How are you feeling?" She said, "Well, I'm feeling not great. I thought I would be feeling better by now. The doctor told me that I should be feeling better, but I don't." So the nurse said, "Oh, well, let me just check your chart," and realized that when she checked her chart, that they gave the wrong device, implanted the wrong device. So a lead was put into her heart, but it was the wrong device. So they disclosed to this patient what happened, that they inserted the wrong device, that they would correct it that day. It should be very straightforward, and that if there was any complications at all for her, of course she was welcome to come back. Do you want to do this today? Do you want to come back another day? Recommend you do it. And she said, yeah, let's just finish this off, which they did. They fixed it, and off she went home. So the patient was fine, aside from there's an increased likelihood of infection when you go back into a pocket, but as far as the device goes, she was okay. The team, however, was devastated. And we found in our investigation and review, there were 4 causal factors identified. One was somehow the incorrect device got put into the schedule for the OR. There was a chart check that was supposed to happen prior to the procedure, kind of a last administrative check, and that missed the error on the schedule versus what was in the chart. There was a discrepancy noted in the procedure room before the patient came in, because one of the nurses pulls the device and has it ready to be tested and inserted into the patient. We had a product rep in the room, and there was a discrepancy noted, and the nurse assumed she was wrong and accepted the device. The rep had identified the device from the schedule, which was incorrect, not from the chart, which is where we're supposed to do that. Then when they did the timeout, the physician came in, he was late, he should have reviewed the chart and talked about the device, and that didn't get caught in the timeout either. So from that, we looked and identified a number of root causes. Now, I'm not going to go through all of these, I'll just hit a couple. This was actually an error where a keyboard got bumped, deleted some of the fields in the schedule, was repopulated, and the wrong item was put in. The chart check was something that is supposed to happen, but when they're resource lean, when they don't have enough people, that's the one thing that often gets missed. The discrepancy, the nurse afterwards, and she was a mess. She said, I should have known. I always check. I don't know why I didn't. I had this little voice, but she trusted the rep's word, and they looked at the schedule, and that was fine, and she should have gone to the chart. If she'd looked at the chart, it would have confirmed that it was the wrong device. And then the timeout did not include all of the details of the device, did not include the full team, and the physician did not verify that from a review of the chart either. So there was this whole idea of trust in the team and an increased pace of a procedure room. This is we've heard it time and time again. I just trusted that they'd done it. So as a result, there were a number of recommendations put into play. Some were physical changes and engineering changes to access to the schedule. We had to create protected time for chart checks, that they weren't allowed to be pulled to other areas. This was the priority. Trying to teach people an all stop. That was a more difficult one, right? An administrative control about if something doesn't feel right, then stop until you can resolve if there's a discrepancy. That's very much a behavioral change. We have a speak up value, teaching people to speak up and listen up, right? So that was a big, tougher one. And then the surgical pause, we modified that surgical pause and included the patient in the initial pause. So the patient knew what device they were supposed to be getting, and if they'd done that pause with everybody, it could have prevented this. And they also talked about maximum cases and last case time to stop that rushing. Because that team did 6 in a day, we're going to do 7. Not because they have to, but they know these patients need these and they will make it work.